Hi, hello everyone. I am Dr. Dola Shekhawat from All India Institute of Medical Sciences, Jodhpur, India. As a part of the PAPERI Policy Advocacy on Genetics and Genomics course 2025, I am representing the Group 6 as an affirmative team. The topic is should newborn genomic screening for the conditions like sickle cell anemia be mandatory to improve the early interventions efforts. As an introduction, the newborn screening is a proven public health strategy for early detection of the serious genetic disorders. And the sickle cell disease is very well known. The inherited hemoglobin disorders is caused due to the mutation in HBPG. The patients with the homozygous conditions leads the chronic anemia, infection, pain crisis, and organ damages. And the symptoms with the newborn baby do not appear at the birth. However, uh, it's begin in the early infancy, and these phenotypes are directly related to the genotypes as well as the co-occurrence of the other hemoglobinopathies. The prevalence of sickle cell anemia is very high, especially in the tribal area or African regions, and the late diagnosis directly leads to the childhood mortality and the morbidity. In the last decades, there is an advancement in genomic technologies uh, which allow the early identification of genotypic condition at the birth. And early diagnosis enables a timely intervention that significantly reduce the mortality and the morbidity. The biochemical screening methods alone cannot be achieved 100% sensitivity. And this arises the question, should the newborn genomic sequencing is mandatory to improve the early intervention? With this, the opening statement for this conditions, what if the life-threatening genetic diseases could be detected on the very first day of the life with the genotype before a child ever becomes sick? So, when the early diagnosis can save the lives, does the society and policymakers have the responsibility to ensure that the newborn is screened and genotypically labeled? With this, the constructive arguments are uh, first, why newborn genome sequencing? So, it's genome sequencing is important because it detected affected infants before the clinical symptoms, clearly understand what is the genotype and what is the phenotype and what are the relation in between, and definitely early detections allow uh, to make a proper diagnosis or early diagnosis which is directly leads associated with the uh, take a proper action like prophylactic antibiotics, timely immunizations, education of the parents, genetic counseling, proper follow-up, and these directly proven the reduce in the infant mortality and morbidity. The second constructive arguments, the equity and universal coverage with the genotypes. If we screen all the newborns, we ensure that no newborn should be missed, and this should be in regardless of the socioeconomic status, geographical locations, awareness among the parents. So this should be the voluntary programs and often widen health inequity. And if we know very well about the genotype and the co-occurrence of the hemoglobinopathy, uh, that will directly help to improve the scenario. The third argument is cost effectiveness in the long term. So early diagnosis through the newborn screening is significantly the lower lifetime healthcare cost by the preventing severe complications such as the infections, stroke, organ damage that required the repeated hospitalizations and the expensive treatment later in the life. Definitely, the timely intervention antibiotic prophylaxis, vaccination, the regular monitoring, and the low cost measurement that avoid the high cost emergency care, the blood transfusions, and the intensive therapy in the undiagnosed patients, and investing the early in the screening and the prevention the care is a far more cost effective than the managing the advanced diseases, disability, and the loss of the productivity associated with the late diagnosis. Fourth argument is the integration with the existing newborn screening program. So sickle cell testing can be integrated with the existing newborn screening programs or schemes. And just an example, in India, we are running a newborn screening for 5 to 6 common genetic disorders that includes the uh, G6PD deficiency, 17-OHPHG deficiency, galactose deficiency, and cystic fibrosis, biotinidase deficiency, and phenylalanine conditions. So the sickle cell anemia also can be integrated with these conditions because the sampling and the testing material which required is similar as for all these conditions. The another program which is running by the India, that is called as the Rashtriya Bal Suraksha Karyagram, that is screenings over the 32 health conditions, and the target groups is 0 to 6 year and 6 to 18 years school going children. And this is the mostly focused on the 4D, that is defect of birth, disease for common illness, deficiency belonging to nutritional gaps, and developmental delay and disability. And after the registering the child, we take a proper follow-up of the children and the proper monitoring with the subsequent the follow-up. So with this is such a beautiful programs, sickle cell anemia also can be integrated, and no major additional burden when the phase appropriately. So fifth is the strengthen the preventive healthcare system. So newborn genomic screening strengthen preventive healthcare system by promoting the genetic counseling, structured follow-up, and early risk-based interventions. It generate reliable population data for public health planning, enable target programs and resources, and allocations of inherited diseases. And the program also builds the national capacity for genomic medicines, preparing the healthcare system for borderline precision healthcare initiation. So, with these constructive arguments to the final key arguments. So, when a condition is common, the serious, detectable at the birth, and treatable early, the newborn genomic screening is not just a beneficial; it is a ethically justified. In a subsequent slides, we will discuss about the rebuttal part, which is raised by the negative team. As the first claim alleges the violence of a children's rights to in the open future. So definitely, rather than the violence in the children's rights to in the open futures targets, newborn genetic screening preserve the future autonomy. And the newborn screening is designed to protect, not restrict the future autonomy. Screening does not remove the children's ability to make a future choice. The prenatal decisions making in early life is ethically accepted, and the appropriate scopes and the data governance is the protect autonomy. The second claims the discovery of known paternity in genetic screening. So genetic screening for conditions like sickle cell disease does not inherently require disclosure of the biological paternity. No disclosure policies are the well established in the medical genetics. Informed consent and the pre-test counseling significantly mitigates the harms. Ethical obligations to protect the children's healthcare takes uh, precedence over the social assumptions of percentage, withholding the effective screening due to the possibility of the social harms risk, reinforcing inequity. The third claims overdiagnosis and the patients in waiting. So while the screening may detect the mild variants, careful interpretation, genetic counseling, and the risk-based follow-up prevent unnecessary medications. So screening programs are designed to identify the clinical actionable conditions. A positive screening results is not adequate to a clinical diagnosis. Genetic counselings play the critical role in preventing and the patient's voting phenomena. The potential harms of overdiagnosis must be balanced against the significant benefits to the early detection. The significance programs are continuously refined. The fourth claim, Vulnerable child syndrome. Although disclosure of the carrier status may raise the concerns about vulnerable child syndromes, effectively the genetic counseling and the clear distances between the carrier states and the disease prevent the unnecessary psychological harms, while the uh, preserving the beneficial of the screening. So we need to be clearly mentioned the carrier is a carrier haven't any disease, and there is no harm in the future. Uh, in this scenario, genetic counseling is centered to prevent the misinterpretations. Evidence that established screening programs show the consist long-term physiological harms. Early knowledge in the carrier status can be positively psychological values. The ethical priorities remains the children's best uh, interest. The fourth claim by the negative team, the increase the fear and anxiety among the parents. Although the initial anxiety may occur, uh, but the clear communication and genetic counseling transfer the career information into the empowerment, reducing the fear and the self-balance, while the supporting the informed family decision. So we should tell very clearly the career is not belonging to a disease, and but in the counseling session we should clearly mention how the career uh, can be associated with the pathological conditions in the next generation. Early knowledge can be empowering rather than the harmful. The evidence from the population screening program indicates that prenatal anxiety decreases as understanding improves, particularly when the follow-up educations and reassurance are provided. And avoid the screening to prevent the short-term anxiety risk, deny the family values health informations, and may lead to the greater distress later if the affected child is born without the awareness or the preparation. The fourth claim, justification and stigmatizations. So universal newborn screening for sickle cell advance justice by ensuring the equal access of early care, and when the paired with the community engagement reduce rather than the reinforce the stigma. So modern sickle cell disease screening is a population based. There is no ethical and the community based. Screening promotes the health justification and address the historical neglection. Community engagement and the partnership mitigates mistrust. Stigma arises from the poor communications, not from the screening itself. So with this constructive arguments in the rebuttals parts, the closing statements are for the conditions like the sickle cell diseases, the question is no longer whether we can detect the disease at the birth, but the whether we can do afford not to. And with this right safeguards infrastructure and the follow-up, mandatory newborn screenings can be transformed the sickle cell anemia from the silent trait into a manageable condition. So now we are with the very important section, that is a question answer session. So first question is, so why genomic newborn screening when the biochemical screening can identify a sickle cell disease? So yes, biochemical screening can identify sickle cell disease. However, there are the limitations. First, the patients with the intermediate HbA2 level. This is very difficult to identify. It is a carrier or it's a healthy. The second, the patients with alpha thalassemia, that also cannot be detected with this biochemical screening test HPLC. So to define clearly that genomic sequencing could be the better option. The genomic screening reduces the diagnostic ambiguity. Second question, is it ethically correct to report adult onset conditions in the newborn genomic screening report? So, so for that, definitely there is a ethical concern. So for that, we need a very clear consent and documentations, as well as a very good genetic counseling services. And we should very clearly explain to the parents when the newborns get diagnosed with a carrier status or a disease status. Third question, what safeguards are essential to prevent misuse of genomic data generation at the birth? So that is a very important questions at a country level, not for a newborn level. So that government and the policymakers should take a proper action for that. Should be the robust data governance, a restricted assessment, clear consent policy, the legal protections against discriminations are essential to maintain the trust and ethical integrity. So next question is, how does genomic screening improve the early intervention in sickle cell disease? So definitely, if we are able to screen the disease condition at the very first few days of the life, we can plan the proper care of the children to improve their quality of the life, and can initiate the antibiotic prophylaxis, the proper vaccination, education of the parents, and the regular follow-up of the patients, and can intervene. So in that way, we can reduce the mortality and morbidity. The next is, where should the ethical boundaries be drawn between the public health benefit and individual autonomy in mandatory newborn genomic screening? The boundaries should be drawn whether screening provides clear, immediate benefits, and the children prevent irritable harms while limiting analysis and disclosure to clinically actionable conditions and ensuring the strong data protection. The next question, in resource limiting setting, is genomic newborn screening for sickle cell diseases a justified investment? Yes. So when the target phase genomic screening can be cost effective by preventing several complications, reduce hospital admissions, improve the surveillance, particularly in the high burden populations. How can trust be built in communities historically marginalized and stigmatized by the genetic screening? So that is, it could be possible via the community engagements, with culturally sensitized, and the transparency about the program's goal. Is the next is, how should uncertain or the low penetrance variants be uh, handled in newborn genomic screening? So such variants should not be routinely reported. Instead, screening should focus on variants with strong evidence of pathogenicity and clearly clinical utility to avoid anxiety and confusion.